Okay, so let's move on to the next chapter on pulmonary embolism. And pulmonary embolism is where a fragment or a piece of either air or tissue, blood clot has traveled. It's embolized to the lung, and in particular, it's embolized to a pulmonary vessel, right? Because that's how it got there. It traveled typically through the venous system. So there's other less common ones, such as air emboli, say from a syringe that we're using, and by mistake we put air into the venous system or an IV tubing, and we give an air embolus to the lungs. There's septic emboli, such as if someone has infective endocarditis, so bacteria and clot on a valve in the heart, and if it breaks off and travels to the brain, you could have a septic emboli to the brain. There's amniotic fluid emboli, where some amniotic fluid gets into the venous system and travels to the pulmonary system. There's fat emboli from a long bone fracture. So the bone marrow is full of fat, and that can travel in a fracture to the venous system and then get into the lungs and cause a fat embolism. But in general, we're typically talking about venous thromboembolism. So a blood clot in a vein, most often in one of the legs or in a pelvic vein, and a piece of the DVT breaks off, travels to the heart and then the lung, and blocks one of the pulmonary arteries or pulmonary vessels in the lung, causing a PE. Okay, so let's move on and talk about risk factors, treatment of this condition. It's not an uncommon condition, especially in elderly and especially in people that are on certain medications, such as estrogen. Birth control pills is a risk factor, but we'll get into all the risk factors. Okay, risk factors for developing a pulmonary embolism. Well, they're going to be the same as the risk factors for developing a deep vein thrombosis, right? Because that's where the PE came from. It typically broke off um, a clot in your leg or your pelvis and traveled to the lungs. Okay, so risk factors are the same. So what are the risk factors for either a DVT or, if a piece breaks off, a PE? Long-term immobility. So if you're lying in bed for a long time and you're immobile, the chance of you forming a DVT because of poor venous return in the legs is high. Okay, so definitely a risk factor, and we address that particular risk factor, in particular post-operative patients, that are going to be lying in bed for a prolonged period of time, because it's such a known risk factor. Oral contraceptives with estrogen in them. So estrogen tends to thicken the blood, leading to DVTs and then, of course, PEs. Pregnancies, you have higher level of estrogen. And you also have typically decreased venous return because the developing fetus is starting to put pressure on the pelvic veins. And you can get leg swelling and decreased venous flow from the legs, right? So not only do they have more estrogen, but they have decreased venous flow. Tobacco use, well, cigarettes thicken the blood. Okay, so the chemicals in cigarettes thicken the blood, leading to DVTs and PEs. Obesity is a risk factor because of poor flow in the legs, right? So if you were to bend your knees or sit in a chair, you'll notice that your hip is bent. So the vein's going to be kinked. That's why we tell people that are flying long distances to get up every hour, or at least at a minimum, move your legs frequently. Okay, so obesity is a risk factor because of the decreased venous flow in the legs. Surgery is due to immobility. Okay, lying down, spending a day, 2, 3 days post-op, and there's decreased venous flow. Heart failure. Well, heart failure is a risk factor because if you have heart failure, there's less blood that's able to return to the heart uh, because of the heart failure. So it's backing up into the legs, right? So with that slower, sluggish return of blood comes an increased risk for DVTs and PEs. Advanced age, purely because of potential immobility, damage to the veins over the years. Cancer is a risk factor that you shouldn't forget for PEs and DVTs. So anyone with a history of cancer has a higher risk of developing a DVT or a PE. Anyone with a hypercoagulable state, meaning someone who has really elevated platelets, well, they're going to have thicker blood, right? I mentioned cancer, and I really don't want you to forget that one, because anyone with any form of cancer, cancer tends to thicken the blood and increase the risk of DVTs and PEs. Okay. Any trauma. Why trauma? Well, if you have trauma to the legs, you may have injured the vein, and an injured vein is more likely to clot. And there's a term that we use called Virchow's triad. So Virchow's triad. Okay. And Virchow's triad basically is just reminding you of the 3 factors that predispose you to developing a DVT. So anything that injures the vein is one corner of the triangle. Okay. So any trauma, anything that has previously injured the vein, such as a previous DVT, puts you at risk for another DVT. Okay, let's look at another corner of the triangle. Hypercoagulable state, increased platelets, cancers make your blood thicker, cigarette smoking, estrogen, pregnancy. Okay, that's another corner of the triangle. And the last corner of the triangle would be decreased venous flow, so venous stasis. So if you're not moving very much, if you have a fracture and you can't move that leg, anything that reduces venous return, again, another one is heart failure, decreased venous return, right? So if you think of those 3 parts of a triangle, hypercoagulable, anything that makes your blood thicker, anything that damages the vein, and anything that reduces venous flow, then you're going to have all of the risk factors for DVT and PE. Okay, so let's look at the expected findings. And let's just think about this for a minute before we go through all these. So someone comes, someone has a DVT and a piece breaks off and travels to the lung. That's going to be a pretty sudden event. Okay, so most people that we see have the sudden onset of shortness of breath, pleuritic chest pain, meaning when I take a breath, it really hurts in my chest because it's stretching the pleura that's been damaged from the blood clot. Okay, so shortness of breath, pleuritic chest pain, they can be hypotensive, tachycardic, okay, because the heart is now having to pump more because it's trying to get around this blockage through other vessels in the lungs. Okay. Let's look at, so that's the typical way that they present, but let's look at some of these. So anxiety and impending doom, well, that's because of the shortness of breath, okay? There's been a sudden blockage in one of the pulmonary arteries, which is causing shortness of breath, or sorry, anxiety. Pleuritic chest pain would be the next one. I take a big breath and it hurts, okay? And there it is, pain on inspiration. Okay, pleuritic chest pain. Dyspnea and air hunger, that's just shortness of breath. Some people with PEs can cough up blood, right? They've blocked an artery in the lung, and some of the lung tissue after the artery is dying. So they're coughing up some blood. Tachycardia, okay? There's blockage of blood flow to the left side of the heart. So the heart says, I have decreased cardiac output. I better beat faster. Okay, so tachycardia, hypotension can happen because of less blood going to the left side of the heart. Tachypnea is just breathing fast. Decreased oxygen saturation because the blood is now blocked from going to a portion of the lung that had air there. So it has to go around there and get back to the left side of the heart. So they can have decreased O2 sats because deoxygenated blood is getting back to the left side of the heart. Petechiae, that would only be with a fat embolism. That wouldn't be common with a venous thromboembolism. Okay, so that one I would just reserve for a fat embolism. Distended neck veins. Well, if you have a massive PE that's blocking your pulmonary artery, meaning your right ventricle can't pump because there's a big clot in the pulmonary artery, well, everything backs up, and your neck veins, the blood in your neck veins can't drain back to the right ventricle, right? So they're distended. Cyanosis is hypoxemia, right? Decreased O2 sat. Okay. Okay, let's look at ways of diagnosing a pulmonary embolus. Okay, so someone comes in with shortness of breath, pleuritic chest pain, anxious, maybe coughing up a bit of blood, and we want to see if they have a pulmonary embolus. Okay, so we can order an arterial blood gas. How's that going to help? It's definitely not going to diagnose a pulmonary embolus because even if it's abnormal, many things can cause it to be abnormal. So on the blood gas, they may be hypoxemic. Initially, if someone's breathing really fast, they may have a low CO2 because they're breathing fast, they're blowing off their CO2. But if it's a really large pulmonary embolus and it's clotting up a lot of the lung, they're going to have difficulty breathing gradually and more difficulty, causing backup of CO2 and a respiratory acidosis. So because the CO2 has gone up. So initially it can go down because they're breathing fast, but with large blood clots, they're having more and more difficulty breathing. The CO2 is going to go up and they're going to get respiratory acidosis. Not an accurate test for PE though. A D-dimer is basically a blood test that shows us if there's active clotting going on in the bloodstream. So we could order a D-dimer test. It's not confirmatory though. It just tells us that something odd in the blood clotting of the body is going on. So if it's elevated, we need to go on to a diagnostic test, a confirmatory test. And that would be a CAT scan with dye. So we inject a bit of dye into the vein, we wait for it to travel to the lungs, and we do a CAT scan of the lungs. And that's typically the way that we diagnose pulmonary emboli, with a CT scan with dye, what's called a CTA. Okay, chest x-rays. We'll do a chest x-ray, but we'll never diagnose a PE on chest x-ray. They don't show up on chest x-ray. Sometimes we can see maybe a bit of possible evidence that something looks strange on the chest x-ray, but we can't confirm it with a chest x-ray. Okay. A VQ scan is a very old way of diagnosing PEs. We really don't use it anymore. But it would be a scan where we would see where the air is traveling in the lungs. So that's the V, the ventilation. And at the same time, we would see where the perfusion is traveling in the lungs, and that's the Q. Okay? And where the air is traveling in the lungs and where the blood is traveling should be very similar. If there's a blood clot, meaning a PE, the Q, so the perfusion will be altered because there's a blockage, and it'll be an abnormal VQ scan. We don't use them very much anymore. They're not as accurate as a CTA. Lastly, pulmonary angiogram, where we put a catheter into the vena cava, and then we squirt dye that travels through the lungs the arteries of the lungs. Yes, it's very accurate, but we don't use it very often because we have a CT angiogram that we can use, which is less invasive. Okay, a pulmonary angiogram, angiography is more invasive. Okay. Okay. Now, just like any other disease, pulmonary emboli have a spectrum of disease. You can have a small pulmonary embolus that's just giving someone a bit of pleuritic chest pain and some mild shortness of breath, and we diagnose it with a D-dimer followed by a CTA, and we treat them with anticoagulants. Okay. What does the anticoagulant do? It doesn't break up the pulmonary embolus. So the part that's traveled to the lung already, the body's going to break it up. What an anticoagulant does is it stops further development of the DVT. And by doing that, it prevents breaking of another piece that's going to travel to the lung. So the piece that's traveled to the lung already, there's not much we're going to do for that. Okay, it's going to break up on its own. The body's going to do that. We can definitely provide oxygen. We can definitely provide fluids if they're hypotensive. And I'm going to talk to you about one particular treatment that we sometimes do in a massive PE. But other than that, think of the anticoagulants as preventing further PEs from developing due to an extending DVT, okay, because that's their role. So we can use heparin. Heparin's usually given IV for a DVT. So it's a bit onerous because now the person has an IV. We're having to check PTTs frequently. We can use a low molecular weight heparin, such as enoxaparin, which is just weight-based, and we don't need to check a PTT, right? So they're much easier to use. They give predictable anticoagulation. Okay, we can start someone on warfarin. Remember, warfarin can take 3, 4, 5 days to become therapeutic. So while we're waiting for warfarin to become therapeutic, they need to either be on heparin or enoxaparin because they work right away, right? So the anticoagulant effect of heparin and enoxaparin work right away. Sure, we can start them on warfarin knowing that it's going to take 3, 4, or 5 days for the warfarin to take full effect. And once it takes full anticoagulant effect, we can stop the heparin or the enoxaparin and continue on with warfarin. Okay? Or we now have direct factor inhibitors. So, for example, rivaroxaban, or another one called apixaban. Those are medications that directly inhibit factor 10A in the clotting cascade, and they work immediately. So if someone comes in with a PE and we want to start rivaroxaban or apixaban, we don't even need to bridge them with heparin or enoxaparin. They start working right away. And that's why these drugs have become so popular. Because we don't need to bridge them with heparin or enoxaparin while waiting for them to work, which is what we have to do with warfarin. Okay. Now, thrombolytic therapy. So there's some evidence that if someone has a massive PE, so a huge clot has traveled to the heart and then blocking the pulmonary artery, so there's very little blood that can leave the right ventricle to get to the lungs. So the person's going to be in big trouble. They're going to be hypotensive, tachycardic, respiratory distress. They're in big trouble. There is a thrombolytic we can use, so TPA, that we can squirt into the vein, into a vein that's going to travel to the heart and then travel to the massively clotted pulmonary artery and try and break up the clot. Okay, that's fibrinolytic therapy for a PE or thrombolytic therapy. Okay, when I was talking about anticoagulants, that was to prevent the DVT from breaking up another piece and traveling to the lung. The thrombolytic therapy is meant to try and break up a massive PE. I don't want you to get the idea that we use thrombolytic therapy very frequently for a PE, because we don't. Okay, but it's a kind of a Hail Mary when someone has a massive PE and we don't have anything else to offer, and we want to try and break up the clot in the lung. Okay. Now, what else can we do if someone's getting repeated PEs? So they're on blood thinners for their DVT, but they continue to send PEs to the lungs. Well, we could put a filter in the inferior vena cava. So the filter gets inserted. It's almost like a protective filter. So when a clot travels up from the leg, the filter stops it. Okay, it doesn't let it get to the heart. Okay, so that's called an IVC, inferior vena cava filter. What else could be done? Again, this is a bit of a Hail Mary, but if someone comes in with a massive PE, okay, we could try TPA, so that thrombolytic therapy, or they could be rushed to surgery and see if an embolectomy is possible, where they open up the chest, get into the pulmonary artery, and see if they can get that massive clot out. Okay, not very common. Again, it's something that's sometimes offered as a last-ditch effort to try and save the person. Okay. In general, the treatment for PEs is maintaining oxygenation, maintaining blood pressure, and some form of an anticoagulant. So remember, if someone starts on heparin, how do we follow the blood thinning effect of heparin? PTT. If someone is started on enoxaparin, how do we follow the blood thinning effect of enoxaparin? We don't need to. It's weight-based. So nice and simple. Warfarin, so that inhibits vitamin K-dependent clotting factors from the liver. We use INR, right? INR, or the older one, PT, prothrombin time. We use INR much more frequently now. It should be between 2 and 3 if it's therapeutic. Okay. How do we monitor direct factor 10A inhibitors for their blood thinning effect? We don't need to. Okay, they have a fixed dose, and there's no need to monitor them, which is awesome. What do we care about the most with all of these anticoagulants and antifibrinolytics? Bleeding. We need to monitor for bleeding, right? And we need to ask about bleeding conditions before giving them. So, have you had a gastrointestinal bleed? Have you had a recent stroke? Have you had recent surgery? We want to know all those things because that's going to increase their bleeding risk. Once we administer them, we want to tell them. If you have bleeding in your gastrointestinal system, such as melena or vomiting blood, or excessive bruising and bleeding, you need to let us know. Okay? So all these anticoagulants, it's always the same thing. It's all about bleeding risk. Okay? Okay, so remember, most pulmonary emboli originate from a DVT, right? And the risk factors can easily be remembered if you remember Virchow's triad, right? One corner of the triangle, hypercoagulability states. So estrogen, smoking, cancers, things like that. Another corner, decreased venous return or venous stasis. That's immobility, obesity, congestive heart failure, anything that's slowing down the blood flow back to the heart. Okay? And injury to the vein. So a trauma to the leg, a crush injury to the leg, a previous DVT, anything like that that's injured the vein in the past can lead to development of a DVT. Okay, Virchow's triad. Okay, so patient education, so decreased clotting factors. So how can we decrease the clotting risk? Well, smoking. Smoking thickens the blood, right? So education about quitting smoking and potentially treatment about for quitting smoking. Avoiding prolonged periods of immobility. So if you're on a flight for 10 hours, say you're flying to Canada, that's not 10 hours, but say you're flying to Canada, getting up every hour, moving your legs so that there's venous flow, right? Remember, when you're sitting on an airplane, your knees are kinked and your hips are kinked. So there's decreased venous flow, okay? So avoiding prolonged periods of immobility. And the same thing would go for avoiding crossing the legs, because what are you doing? You're kinking a vein. And remaining well hydrated. If you're well hydrated, you're keeping the venous flow very good, right? If you're dehydrated, the venous flow is slowing down, the blood's getting sluggish, right? And venous stasis is a risk factor for getting a DVT. Now, if we were to use warfarin, which inhibits the vitamin K dependent factors in the liver from being produced, we typically tell people just continue on with your regular diet. So if it's someone that eats lots of green leafy vegetables and that's their regular diet that they're going to continue for the next 20 years, that's fine. We can adjust the warfarin based on your diet. But if suddenly someone that's taking warfarin starts eating lots of vitamin K in their diet, it's going to decrease the effect of warfarin because vitamin K is the reversal agent for warfarin. Okay, so we adjust warfarin based on someone's diet, but we want to know if they're changing their diet so that we can monitor their INR, and we may need to adjust the dose of warfarin. Okay, so monitoring of INR is at the longest 1 month. At the beginning, it's typically a few times a week while we're adjusting the warfarin dose to make sure that we're not getting too thin in the blood, and that would mean an elevated INR. So if someone has an INR of 5, that means their blood is getting really thin, and sometimes we have to give people a dose of vitamin K just to thicken their blood a bit more, get it back between 2 and 3, which is where we want the therapeutic dose of warfarin to be. Okay? We warn people about the risk of excessive bruising, GI bleeding, melena, anything like that while they're on warfarin because we want them to report back to us. Okay? Sometimes somebody's INR can become very high, dangerously high, and they need to report the excessive bruising and bleeding, and we'll check an INR. And if it's higher than 3, we may need to adjust their warfarin and give them a bit of vitamin K to decrease the INR that day. Okay, so let's do the questions at the end of the chapter on pulmonary emboli. 1, a nurse is caring for a group of clients. Which of the following clients are at risk for a pulmonary embolus? A client who has a BMI of 30. So 30 would definitely be overweight. So overweight and obesity is a risk factor for PEs. Why? Decreased venous return. So obesity causes more kinking at the knee and the hip. And obesity, by the way, you typically produce more estrogen. Fat cells make estrogen. That thickens the blood. Okay, so that would be an answer. That would be a correct answer. B, a female who is postmenopausal. No, that shouldn't be a risk. That shouldn't be a risk factor because, in actual fact, she's not even making estrogen anymore. So there's no risk factor there. A client who has a fractured femur, absolutely, they're going to be immobile. And on top of that, they've had an injury to the leg, and they've possibly injured the vein. So there's 2 corners of Virchow's triad, right? An injury, so a venous injury potentially, and immobility, and that's decreased venous stasis, right? So trauma and venous stasis, increased risk of PE there, and DVT. A client who is a marathon runner, no, they don't have any risk factors for a PE. A client who has chronic atrial fibrillation. Okay, E, a client who has chronic atrial fibrillation. I think that's a sneaky one. So why would atrial fibrillation be a risk factor for developing a PE? Well, we know that in the left atrium, you can form clots that can then travel to the left ventricle and be pumped out and cause a stroke. Well, let's look at the right atrium. The right atrium could actually form a clot that could travel to the right ventricle, that could then be pumped to the pulmonary system and cause a PE. I think that one's a bit sneaky, but that it is a possibility. So the answer is A, C, and E. 2, a nurse is assessing a client who has a pulmonary embolism. Which of the following manifestations should the nurse expect? Bradypnea is slow breathing. No, they'd be tachypnea. A pleural friction rub. So it is possible to develop a pleural friction rub. Remember, I mentioned that when you get a blood clot, it's blocking an artery to part of the lung, and that can also block supply to the pleura, and it's going to cause inflammation of the pleura. And when you take a big breath, you may have a pleural friction rub. So B would be right. C, hypertension. No, typically they're hypotensive because there's a blocked artery to get blood from the right side of the heart to the left side of the heart, right? So hypotension can occur. Petechiae, this one's a bit, I think this one's a bit mean. This would be more in relation to a fat embolism. Fat emboli, you can get petechiae on your upper chest and neck area. Typically in a pulmonary embolus from a blood clot due to a DVT, you don't usually get petechiae. So I think that one's a bit mean. E, tachycardia, absolutely, right? Fast heart rate because of decreased return of blood to the left side of the heart, and the heart tries to maintain cardiac output by increasing heart rate. So the answer is B, I guess D, and E. Now I'm just going to mention on that question that I really didn't like the answer D, but they're asking, which I think is a bit misleading, a client who has a pulmonary embolus, which of the following manifestations should the nurse expect? Well, usually when you say pulmonary embolus, we're referring about a blood clot traveling from a DVT. But they're kind of using this as any kind of embolus, whether it's a fat or air or blood clot from the legs. So, I mean, I guess in that case, if you include fat embolism, then petechiae would be correct. I still think it's a bit unfair, though. Okay, number 3. A nurse is reviewing prescriptions for a client who has acute dyspnea and diaphoresis. So they're really short of breath and they're sweaty. The client states, I'm anxious and unable to get enough air. Vital signs are 117, so they're tachycardic. Respirations are 38, they're tachypnic. Temperature is 38.4, and blood pressure is 100 on 50. Which of the following nursing actions is the priority? Notify the provider, administer heparin via IV infusion, administer oxygen therapy, obtain a CAT scan. Well, let's go back and look. So they don't give an oxygen saturation, okay? But in situations like this, ABC, right? Just revert back to airway, breathing, circulation, okay? But the problem is they don't give an O2 saturation. So I think that's a bit misleading. But do you need to notify the provider right away? I think it would be done in combination. I don't think it necessarily has to be the first thing. Providing oxygen would be necessary. Giving fluids for hypotension would be a good idea. The person's not terribly hypotensive, but they're breathing fast. They're breathing at 38 per minute. So I guess the answer should be C, giving oxygen. I just don't see an O2 sat, so again, I don't find it an overly fair question. Okay. Because just because you're breathing fast doesn't mean your oxygen is low, but we're kind of inferring it here. Number 4, a nurse is caring for a client who has a new prescription for heparin therapy. Which of the following statements by the client should indicate an immediate concern for the nurse? I'm allergic to morphine. No, morphine's an opioid. Heparin's an anticoagulant. Not a problem. I take antacids several times a day for my ulcer. Ooh, that's concerning. If you have an ulcer and then I give you an anticoagulant, I just may make that ulcer bleed. Okay, so remember, we always ask about bleeding conditions prior to starting anticoagulants. So that one's a concern. I had a blood clot in my leg several years ago. Okay, that's not immediate concern. You're about to get a heparin. You're about to get heparin. It hurts to take a deep breath. I don't think that's an immediate concern. Why? Because they may be receiving the heparin for a pulmonary embolus, right? So they have pleuritic chest pain. It hurts to take a deep breath is pleuritic chest pain. And the heparin is to treat a pulmonary embolus or a DVT. So I think the answer is B here. Number 5, a nurse is caring for a client who is to receive thrombolytic therapy. Which of the following factors should the nurse recognize as a contraindication to the therapy? Okay, thrombolytic, I'm looking for bleeding conditions, I'm looking for severe hypertension, and if I gave a thrombolytic, I might make someone bleed because of the high blood pressure. I'm looking for recent surgery. So A, hip arthroplasty 2 weeks ago. They had hip surgery 2 weeks ago. That's a definite risk of contraindication for giving a thrombolytic. Elevated sedimentation rate. That's just a test we use for general inflammation throughout the body. So that wouldn't be a contraindication to be giving a fibrinolytic. Incident of exercise-induced asthma 1 week ago. No, that has nothing to do with bleeding or bleeding risk. Not a problem. Elevated platelet count. No, in actual fact, elevated platelet count could lead to clotting, and we're giving an anticoagulant or a fibrinolytic. So that's not a contraindication. So it's definitely A.